Hi, my name is Dan, and today I wanted to talk about cannabis in the treatment of depression. I've been reading a fair amount of the evidence that's out there, and I was surprised to see that there aren't any randomized trials to support or disprove using cannabis for depression. Most of the evidence or studies that's out there comes from population trials or surveys or generally low quality evidence. So I wanted to discuss some of that evidence that I was able to find and go through some of the studies, but I also wanted to talk about some of the backgrounds and some of the history of cannabis. To start with the background, cannabis or marijuana is a plant. From a terminology standpoint, cannabis is an agreed international term, and marijuana is a term when used in the US, particularly it's used for law, like in legal papers or law documents, it will be referred to as marijuana. And I'll talk a little bit more about the naming between the two as I progress through the video. So cannabis is a plant. There are two primary classifications. So there's cannabis sativa and cannabis indica. There's a potentially third classification called cannabis ruderalis. The cannabis sativa plant grows a lot taller, and it's in general classified as having higher THC concentrations and causing more of the high from these plants, whereas cannabis indica is a shorter, stockier growing plant and potentially has more CBD to THC and causes more of the stoned feeling that can happen with these types of plants. Hemp, which is another classification, it's a type of cannabis sativa, but it has very, very low THC percentages, typically less than 0.3%. So it's not going to be psychoactive, it's not going to get into the CNS and cause any effects like being high. These plants contain many different chemicals called cannabinoids. I already briefly talked about THC and CBD, which are the two most commonly discussed cannabinoids. And as the plant matures, it converts CBD into THC as it reaches its floral peak. So you'll hear about different ratios. Some plants have really high THC to really low CBD. The opposite of that, some are 50-50, and then you can find ratios in between that as well. THC has psychoactive components, whereas CBD is minimally psychoactive and has other uses. These chemicals bind to receptors that are found naturally in the body. These receptors are called cannabinoid receptor type 1, and then there's a cannabinoid receptor type 2. And at these binding sites, cannabinoids are agonists. So the system that's naturally occurring in the body with the receptors and certain neurotransmitters that bind to that is called the endocannabinoid system, which simply means the cannabinoid system that is in your body naturally. Receptor type 1 accounts for the euphoric effects and psychological effects of cannabis. It's located primarily in the CNS, which stands for central nervous system. Receptor type 2 modulates immune function, has a utility in pain, and is widespread throughout the body, but it's also found in the CNS as well. The concentration of cannabinoid receptors varies greatly based on the part of the brain. So in the hippocampus, which is a part of the brain, there's a high amount of cannabinoid receptors, and the hippocampus is critical for the formation of new memories. So cannabis use may affect the formation of new memories. Also in the cerebellum and basal ganglia, those are areas of the brain that are critical for fine-tuning movement and coordination. There's a high amount of cannabinoid receptors there as well. In the brainstem, which is the most primitive part of the brain that's necessary for respiration, breathing, heart rate, other primary functions of life, there are no cannabinoid receptors located there. So that's why you will often hear that it's virtually impossible to overdose on cannabis, because unlike other substances like opioids or alcohol, that can suppress breathing and suppress basic life function at high doses. Like I was just saying, there's no receptors on the brainstem for cannabis to affect that area. So next, I wanted to briefly go into history. I found some pretty interesting historical facts about cannabis that I thought was interesting to bring up in the video as well. So cannabis has been a part of human history for thousands of years. I found it interesting that THC was found in the remains of a mummy in 950 BC, and then there's a cultivation record, so a written record from China in 28 BC. And I'm going to skip around through history quite a bit and not go through each time frame, but fast forward well past then to 1545, cannabis was brought to the New World by the Spanish. So then, in another jump forward, in the 1920s, prohibition started in the United States. So people were looking for other substances, other chemicals, other things to do. So cannabis started to be used more for psychoactive properties and other properties rather than the historic hemp farms that were used for fiber, cloth, seeds, other things like that. In the 1930s, the Great Depression happened. So the biggest economic downturn in the industrialized world happened, and people were looking for things to blame that weren't themselves. They were looking for others to blame. So one of the groups of people that got some of the blame were Mexican immigrants and the habits that the Mexican immigrants did, one of which was smoking cannabis. So it was during that time that cannabis was coined with the term marijuana to kind of Mexicanize the phrase to make it seem more negative because they were associating it with Mexican immigrants during the Great Depression. So I found that historical tidbit a little interesting. After the 1930s, there were high criminal penalties put in place for cannabis possession. In the 1950s, you could go to prison for 2 to 10 years just for possession of cannabis. Then in the 1970s, it was classified as a Schedule I drug, which by definition means that there are no accepted medical uses. It's still in Schedule I, even though there are FDA-approved synthetic cannabinoid products that are used for like chemotherapy, induced nausea and vomiting, and HIV and AIDS. So there's a little contradiction there with it being Schedule I, but a synthetic cannabinoid is FDA approved. A slightly more recent history, things have begun to change. So in 1973, Oregon became the first state to decriminalize marijuana or cannabis. In 1975, the Alaskan Supreme Court ruled that a part of a person's right to privacy was having small amounts of cannabis on them. So another vein of decriminalization. In 1996, California became the first state to legalize medical marijuana. And then in 2012, Colorado and Washington legalized recreational cannabis, with the sales starting in 2014. Just like any chemical, any substance that's put into the body, there can be side effects with cannabis. Some of the more common side effects are headache, dizziness, drowsiness, dry mouth, and psychological changes that can include paranoid thinking. Smoking cannabis can also cause a significant increase in the heart rate. So I found an interesting study that showed a 4.8-fold increase in myocardial infarction, so heart attacks, up to 3 hours after smoking. So that change in heart rate can be clinically significant, especially in people that have cardiac abnormalities or a history of cardiac dysfunction. There are potentially long-term effects with cannabis as well. It looks like it can cause potentially hormonal changes. So I saw some evidence for abnormal menstruation and sexual dysfunction over long-term use. Going past side effects and into the safety, I talked about how there's no cannabinoid receptors on the brainstem, so there isn't that potential for respiratory depression or overdose in that regard. It seems like there's a potential for lung cancer if the cannabis is burnt, if the plant matter is burnt. So the burning of organic hydrocarbons and smoke inhalation can increase the risk for lung cancer regardless of what the plant matter is. So tobacco has that risk. Cannabis probably has that risk as well. If you went outside to a bonfire and put dried leaves on the fire and inhaled that smoke day after day after day, you would probably be at an increased risk for lung cancer as well. I actually found two studies in regards to this, and one study from New Zealand showed lung cancer was increased by 8% for each joint year of smoking. But then I found another study of 4,000 patients that didn't show that association. So just like all the evidence that I'm seemingly seeing for cannabis at this point, there's contradictory evidence on both sides of pretty much everything. So just like other drugs and other chemicals, there are drug interactions with cannabis as well. So the cannabinoids in cannabis can affect liver function. So your liver is what metabolizes a lot of drugs and substances that go into the body. And depending on which pathway of the liver that drug is metabolized through, cannabis induces some liver enzymes, so makes them stronger, so you can punch through certain substances more quickly. And then through other pathways in the liver, it inhibits the function, so it would take your body longer. So depending on what the medication is and the drug interaction is, cannabis can sometimes increase other drug levels or decrease. And just like all medications, there's going to be drug interactions, so this is something that a pharmacist could help with or run a drug interaction check. So just wanted to comment that there are drug interactions with cannabis. Next, I wanted to go into some of the evidence that I could find. I couldn't find any randomized controlled trials for cannabis for depression. So if anyone knows of anything like that, please feel free to send something my way. I'd love to read something along those lines. What I was able to find was studies that are surveys or population studies or more less quality passive type of evidence. So the first trial I wanted to talk about was a survey of 4,400 patients, and this survey compared depression scores of never users to users that used cannabis products once per week or less, so not a high amount, and then compared that also with cannabis users that used every day. And like I said, they looked at depression scores. So the scale they used was the Center for Epidemiologic Studies Depression Scale, which is abbreviated CESD. And what they found was the weekly or less users reported the lowest level of depression, followed by the daily users, followed by the highest amount of depression in the never users. And like I was commenting on, this was a survey, so there's always issues with surveys. You don't necessarily know if people are answering truthfully, the quality of the evidence in that regard, because you're not comparing it to other things. So a survey falls back a little in the quality of the evidence, but it's still worth noting and worth commenting on that there was some differences noted between these different populations. A second study that I was reading was pretty interesting. It analyzed data from an app called StrainPrint. It looks like it's a Canadian-based app, but I could be wrong in that regard. And what this app does is it allows medical cannabis users to track different symptoms that they have based on the strain and type of cannabis product that they're using, and also comment on dose as well, based on number of puffs and so on. So what this trial looked at was 1,399 individual medical cannabis users who were using the app to track anxiety and depression scores. And what this app showed was that users perceived a 50% reduction in depression and a 58% reduction in anxiety and stress scores after using cannabis. And then, like I said, they could comment on the type of cannabis product that was used as well. So the people that were using high CBD to THC ratios noted more of a decrease in their depression scores than the people that were using a high THC to low CBD. So this information is starting to get somewhere. It's starting to tell us the differences between these cannabinoids, how they can affect depression. Another part of the trial was dose, and it seemed that the users that said they only used one puff had just as much effect on depression and anxiety as the people who used 10 plus doses, which is interesting that the dose effect can start so early. Just with one puff can cause that. And it looks like the depression scores didn't do better for the people that would do up to 10 plus puffs. So the decrease in depression scores was pretty much the same regardless of dose. Now, this study also has potential variables as well. One that I think of is that the people that are going to be using this app are going to be the people that have success in using cannabis for depression and anxiety. So if someone tries a cannabis product and doesn't have a decrease in their depression or anxiety score, they're not going to continue to use it for depression and anxiety. So this is only capturing a subset of people that have that effectiveness. So there might be a large population of people that don't get the effect. I mean, it's possible, so I just wanted to comment on certain aspects of the trial in that regard. A third trial that I wanted to comment on was a study that looked at data on suicides in states where cannabis has been legalized. And they used the National Center of Health Statistics mortality details files. So they used government data to look at suicide rates, like I said, in states where cannabis products have been legalized versus in states where it hasn't been. And if you've seen some of my other videos or read some of my other articles, there's not many substances that have been proven to decrease suicide rates. One being lithium, one being clozapine, an antipsychotic medication. Potentially ketamine might have a role in that regard, but that's pretty much it. All the antidepressants don't seem to cause that decrease in suicidality. So when I read something about this, it really piques my interest because that's the most severe symptom, if you will, of depression, because it's the part that ends someone's life is suicide rates. So the study was looking at suicide rates in the states where cannabis has been legalized, and they found an overall 5% decrease, and they included suicide trends in the study, but an overall 5% decrease in these states. When you broke down certain age ranges and gender subtypes, that 5% could be increased. So there was 11% decrease in suicide rates for males 20 to 29 years old, and then a 9% decrease in the suicide rates of males 30 to 39 years old. So that could be huge when you're looking at whole state data worth of populations and mortality. That's a pretty large sample size. You're accounting for thousands and thousands of people, depending on the state, millions of people. What it didn't find was decreasing suicide rates for females under 40. So younger females didn't seem to have a decrease in suicide rates in these states, and older females only had a modest decrease. So I found that interesting, that it's certain genders and certain age ranges that seem to have this effect. And I think that this definitely warrants the potential for more studies. Because like I said, there's not many things that have been proven to decrease suicide rates. Not all of the evidence is positive. There are population trials that show potentially a connection between cannabis use and depression. So one study that I found from Australia followed patients from birth to 21 years of age. Those who started cannabis before the age of 15 and then used heavily up to age 21 were more likely to report symptoms of anxiety and depression compared to the people that used it less. This was seen after adjusting for confounding variables such as gender, maternal marital status, so like parental factors, family income, maternal mental health, so genetics, and that relationship was still seen. They also saw this relationship in cannabis as compared to those who use cannabis and other illicit drugs. So there wasn't an increase in the people that used other illicit drugs, just in the cannabis as a whole. So there are negatives to population trials like this as well. So this study is concluding that the people that use cannabis frequently have higher rates of depression, therefore there might be a connection. But to provide like an analogy or a thought that I had is that if you can imagine, say, a prescription antidepressant, like we'll just use Lexapro as an example, became over the counter. You could buy it at the pharmacy without a prescription. It's available to whoever needs it. And then you track the people that bought Lexapro over a year and correlated that with depression, you're going to see the exact same thing, because the people that are buying the Lexapro are going to be associated with depression because they're using the Lexapro to treat depression. So that potentially could be what's happening in this Australian population, that it's not that the increased cannabis use is causing the depression, but just that the people that have depression are using more cannabis to try to self-treat. So I hope that analogy made sense, and that's what went through my head when I read this trial. I found a meta-analysis, which is a trial that is composed of many different trials and conglomerates the data to get a lot higher amounts of patients in it. So this was a meta-analysis of 14 articles of longitudinal studies, so long studies that looked to see if there was an association between depression and cannabis use. What they found in this meta-analysis was they looked at odds ratios. So the odds ratio for cannabis users developing depression compared to controls was 1.17. So the cannabis users were 1.17 times more likely to develop depression than the controlled population. And then for heavy users, this was increased to an odds ratio of 1.62. So heavy users of cannabis were 1.62 times more likely to develop depression. So again, this could be my critique of the last trial. It's hard to say. It's just a potential speculation that potentially the users of cannabis are self-treating and not causing the depression to occur. They're trying to treat the depression by using more. So there's negatives to these types of trials that are reviews of studies and reviews of populations over the long term, and the use of surveys where people could have ulterior motives and not answer truthfully. So a lot of this data that's out there, what I'm trying to say, isn't necessarily high quality data. And in both the positive and negative trials, I have critiques of those. So what I'm shocked that I couldn't find any, even small scale or trials in different countries, I couldn't find any like randomized controlled trials. So what I think needs to happen is something like a randomized active controlled trial. And why I say active controlled over placebo controlled is that if someone's taking a cannabis product, they're probably going to notice some changes, some effects. So they're going to know if they're on the cannabis product rather than the placebo. So I think a trial that would look something like this would be extremely helpful. So maybe it can be small scale, take 40 people with depression who have failed 2 or 3 prescription antidepressants. Split that 40 into 20 and 20. Give 20 cannabis product and give 20 an active control, maybe something like benzodiazepine, like lorazepam or something that won't necessarily be helpful for depression, but will cause some changes, so it will help with the blinding of the trial. You don't necessarily know what group you're in. And then in regards to the cannabis product, there needs to be a difference with cannabinoids. So maybe start with one trial where it's 50-50 THC to CBD, and then do a second trial where it's 100% CBD, no THC, and then do another trial where it's 100% the opposite and 0% the opposite. And then track depression scores over a month, 2 months, 3 months, like they do in other depression studies. So that's the kind of evidence that we need to see, one, what dose would be effective, two, what specific product, which cannabinoid is more effective than others, or if it is a combination of them, and then three, to try to have some kind of blinding to reduce the placebo effect that can happen, or the active effect when people know they're getting something over placebo. So that's what I think I need to see, and I'm surprised that it's not out there that I could find. So I'll still be looking for more trials, but I wasn't able to find anything like that. So I hope this background of the cannabinoid system, some of these different chemicals, some of these trials that are positive and negative was helpful. I know it's just mostly informational, and I didn't really provide a conclusion because I don't think anyone can at this point based on the evidence I was able to find. So I hope this was helpful, and thank you for watching.